Good afternoon. Thank you for taking time with us today. My name is Natasha Goins, and I'm a nurse practitioner with surgical oncology. I want to take the next little bit to discuss taking care of the oncology patient during the perioperative phase. As we all know, surgery is an integral component of the cancer journey. And regardless of the exact timing of when surgery plays a role in the patient's specific treatment plan, we all have times that we're involved with the patient during the pre and post-operative window. As critical as surgery can be to their treatment plan, we as clinicians often have to make a decision as to whether or not the timing is appropriate, if it is in the best interest for the patient. Most patients, after discovering they have the diagnosis of cancer, immediately want to undergo surgery. They'll often say, let's just get this tumor out of my body. But we also know that the literature tells us that surgery alone is not sufficient in providing adequate, meaningful benefit for our patients' treatment modalities. After careful multidisciplinary discussion and individualized patient care, we decide that surgery is appropriate for the patient and begin that process. As clinicians, we try to do our best to utilize tools to help us facilitate whether or not it is the right thing for them. Several factors come into play and that we make take into consideration. The first thing we have to consider is whether the patient is too high risk for surgery. One of the things that we look at to assess this is a patient's functional status. So we often say, okay, this patient is too old because they're this age, whatever that age may be. But age is just a number. We've learned in the past that age is more of a function of their functional status. A patient can be 50 years old but have a functional status of an 80-year-old. As vice versa, an 80-year-old may have the functional status of a 60 or 70-year-old. One way that we can evaluate functional status is an ECOG score. As you see on the right, you can see an ECOG evaluation tool that shows the score is valued between 0 and 4. The ideal surgical candidate would have an ECOG score of 0 to 1 or 0 to 2. Some ways that you can visibly assess this in the clinic is to have the patient ambulate. As they get ready to ambulate, watch their gait. Are they steady? Do they require assistive devices? How well do they use those assistive devices? How's their grip strength? We often will call this the eyeball test. Did they pass it? If they did, we understand that they may be able to tolerate the operation. So we next go to evaluate their comorbidities. As we all know, comorbidities play a huge impact in the patient's overall health. Some of those comorbidities may include cardiovascular disease, pulmonary disease, renal insufficiency, liver disease. We have known that uncontrolled diabetes plays an extreme role in whether or not they're able to recover or if their postoperative complications may be higher. Nutritional deficits, especially in the cancer patient, whether obesity or cachexia, play a significant impact in their ability to recover as well. There's several risk stratification tools that we can commonly use, such as the ASA score, the Charleston Comorbidity Index, the Revised Cardiac Risk Index, or the American College of Surgeons NISQIP Surgical Risk Calculator. All of those are used to aim and risk stratify the patient and their ability to tolerate the operation or their potential risk for mortality or morbidity. As previously mentioned, nutritional status can play a large part in the patient's success. Often patients will have had weight loss prior to their diagnosis, which is worsened while undergoing any type of neoadjuvant chemotherapy. It's crucial to evaluate whether the patient has worsening signs or symptoms of nutritional decline and provide resources and support for the patient and their families. Some patients at the time of their diagnosis may require a J tube or a PEG tube to be placed at the time of their portacath to help with additional nutritional supplementation. During the phase of completing chemotherapy and surgical intervention, we place a heavy emphasis on repleting them nutritionally. Oftentimes, PO intake is not sufficient, and so they require additional supplementation with either J tube feeds or sometimes even IV nutrition, such as TPN. This slide shows a great simple graphic that allows even nurses and other support staff in our office to be able to use validation tools to help with screening for patients. The most common is the Malnutrition Universal Screening Tool, also abbreviated MUST, the Nutritional Risk Screening Tool of 2002, the Malnutrition Screening Tool, the Mini Nutritional Assessment Tool, Nutritional Control, the short nutritional assessment questionnaire, and then Nutri-Score. which is the only specified nutritional score for oncology patients. As you can see, you can use any of these. There's close to 70 resources that are available to screen the patients. We know that if they have unintentional weight loss of greater than 5%, ONS recommends that they meet with a dietitian or a clinical nutritionist. For patients that have had or are unable to meet greater than 60% of their requirements for nutritional needs, they would strongly recommend or benefit from artificial nutrition. We know that disease-related malnutrition and cancer cachexia can be associated with inflammation and represents the most severe forms of malnutrition. Cachexia is recognized or characterized by muscle loss that cannot be completely reversed with conventional nutritional support. We do know that cachexia is associated with 20% of cancer mortality. If patients have lost, again, more than 5% of their weight over the last 30 days, they do strongly recommend that they see a nutritionist, a dietitian, or have nutritional support in addition to their daily nutrients. We know that chemotherapy, immunotherapy, radiation therapy, as well as immunosuppressive diseases or drugs can also impact a patient's ability to recover. It's important to monitor labs as well as discuss when stopping one form of therapy and transitioning to the next, especially when completing chemotherapy or radiation therapy and then trying to time that with surgical intervention. Most patients need approximately 4 to 6 weeks to stop any other modality to basically prehab or prehabilitate prior to surgery in order to optimize their nutrition and their functional status prior to undergoing the operation. As we transition from discussing potential surgical risk factors, we will focus our attention now on common postoperative complications. This cartoon graphic here states it's a straightforward operation, but there can be complications such as growing wings and wearing a halo. It seems kind of comical, but truthfully, our goal is never to actually hurt the patient. And although it's never the goal, unfortunately, it can be true, which is why we take an extreme caution into trying to select which patients would best benefit from surgery. As we begin to discuss potential postoperative complications, it's important to make sure that we spend a great deal of time talking about the operation itself with the patients and their families. These here are a list of general complications that are associated with any form of anesthesia or any type of operation, but they can be very specific to the operation, which we will later discuss by disease process. So, in general, with any operation, there's always a risk of bleeding, always a risk for infections, whether they're a surgical site infection, a urinary tract infection, sepsis. Patients are at risk for pneumonia, the development of a pulmonary embolism, respiratory failure requiring intubation, as well as thrombolytic events such as a DVT or pulmonary embolism. Some patients can experience an ileus, a bowel obstruction, an anastomotic leak where they were sewn together. And unfortunately, some patients can even experience an MI, an arrhythmia, low blood pressure, stroke, delirium, or unfortunately, death. So, with any operation, it's imperative that you discuss these potential risks, not only with the patient, but with their family member. We're now going to shift to talking specifically through certain operations, as well as the complications that are associated with those specific surgeries. So, to start with, we're going to discuss liver surgery. The liver is obviously a very large organ and has many big blood vessels going in and out of the liver. The risk of bleeding is higher in a patient that's undergoing liver surgery, and it may require a potential blood transfusion. While the risk may be as low as 5%, it's never 0%. And this can be especially important in patients or individuals that have religious preferences that prevent them from receiving blood products. So it's very important to discuss the risk of bleeding as well as what other methods are appropriate and respected by their family and themselves in those instances. Of note, one of the most common encountered postoperative complications in patients undergoing liver surgery is actually a bile leak. As you may recall from anatomy and physiology, one of the primary roles of the liver is to be an irrigation system for bile. While we never intend to leave the operating room with a bile leak, it is possible for that to develop postoperatively at a later date and time. So some may ask, when exactly is that likely to occur? And the vast majority of time, patients will develop a bile leak typically within the first 7 days postoperatively. They manifest in a certain array of symptoms that can be easily detected, such as fevers, chills, a change in their labs, new or worsening abdominal pain, or even something as simple as tachycardia. So, as we assess these patients daily postoperatively, we are constantly evaluating whether or not they may be at risk for this. Although rare, some patients may even experience liver failure or hepatic encephalopathy following a liver resection. There are many things and tools and resources that we use to try to limit this from happening, but unfortunately, it can definitely occur. Now, some of these complications can really be impacted by the extensive liver surgery that the patient undergoes. The liver is divided into 8 segments, as well as divided into a right half and a left half of the liver. The right half is usually attributed to roughly 60% of the total volume of the liver, and the left half is accounting for approximately 40% of the total volume of the liver. So, whether a patient is undergoing a formal right hepatectomy, which would remove about 60% of the liver, or whether they're undergoing a left hepatectomy, which is removing approximately 40% of the liver, some of these risks can be associated with what they undergo. In some select patients, patients may undergo what's called a small wedge resection, where just a small portion of normal healthy tissue surrounding the liver metastasis is removed. Or they may undergo a combination of wedge resections and microwave ablation. In these instances, patients experience a lot less likely to have complications, such as the ones we've mentioned above. Now, if a patient does present with a bioleak, the management can depend on how the patient presented. When exactly did the patient present with the complication of a bioleak? Was it a few days after surgery? Was it the next day after surgery? Timing of that can impact whether or not we do an intervention, such as going to the operating room immediately, or whether or not it's something that can be managed with interventions, such as drains or stents. Most of the time, we're able to get patients, even if they have a bioleak, through the minor bump in the road by doing interventions that don't require us to go back to the operating room. Now, as you can see on the top left picture, there's a picture of bile. It has a very unique and distinct look. That's when a drain's actually been placed, and so then you can see what it looks like. And we want to drain those bile leaks because you can get extremely sick. In the top right corner, you can see that that is a cholangiogram that was shot in interventional radiology, which allows you to see that there is a leak there, as the arrow points out. And then in the bottom image, you can see a picture or a slice of a CT scan that was performed that shows at least 3 biomas, which is bioleaks that have kind of encapsulated or kind of walled off there. And so, depending on how the patient presents, kind of depends on how we manage it. As you can see, bandage it requires that we get imaging to evaluate it, and then working with our partners, either in GI or interventional radiology, to help be able to manage those. Now that we've talked about bioleaks and things that are associated with liver surgery, we're going to transition to talking about potential complications that are associated with gastric cancer. As with liver surgery, gastric cancer and its complications can be determined by what type of surgery that you have. Some patients have surgery that is called a total gastrectomy, which removes the entire stomach. Some patients undergo a distal gastrectomy, which is approximately 40% of the lower half of the stomach. And then other patients remove what's called only a partial gastrectomy. In that instance, it's most commonly reserved for patients that have a gastrointestinal stromal tumor, also known as a GIST. And so you move a very small portion of just the tumor and the underlying healthy stomach. Complications associated with gastric surgery also include an anastomotic leak. A leak can occur where the small intestine is sewn to the esophagus, which is done in a total gastrectomy. The area where the stomach and the small intestine are sewn together during a distal gastrectomy can also leak. Very rarely do you have a leak from a partial gastrectomy, but it's never okay to say never. Patients that have a leak at their anastomosis, where the esophagus is sewn to the small intestine or where the small intestine is sewn to the lower portion of the stomach, sometimes require going back to the operating room, but oftentimes it can be managed non-operatively. In addition to developing an anastomotic leak, patients can also develop an anastomotic stricture. What that means is where the two ends are sewn together, so where the small intestine and esophagus are sewn together in the instance, as we discussed with the total gastrectomy, you can have narrowing where that has been sewn together. The inflammatory process can lead to that narrowing and stricturing, and it may require that an esophagram be done and then require GI to help with assisting with dilation. Some patients may also experience reflux esophagitis. This can be a nuance and it can be very annoying, but it is mostly managed with medications such as Carafate and PPIs. With gastric cancer and gastric surgery, patients develop a symptom called dumping syndrome. Typically, as you can see in this cartoon character here, it occurs 15 to 30 minutes after eating. They can have extreme epigastric discomfort and fullness. They feel like things are not moving well. As a result, this can lead to nutritional deficiencies in either iron, B12, folate. We try to educate patients as well as provide them with diet modifications to help limit this, but it is a common side effect in roughly about 15 to 20% of patients that experience gastric surgery, whether it's a total gastrectomy or whether it's a distal gastrectomy. They sometimes can experience this and often becomes their biggest frustration in the first 6 weeks postoperatively. With time, diet, education, and modification, most of the time this is completely resolved. But now that we've talked about gastric surgery, we're going to transition to pancreatic surgery. And what are the most common complications with pancreatic surgery? Not to be redundant, but just as we talked about with liver surgery and gastric surgery, the type of complications really depends on the type of operation that the patient undergoes. You may all be aware that there's two main operations that are associated with tumors that arise in the pancreas. The first, or most common, is really associated with tumors that arise from the uncinate process or the head of the pancreas, and that's called a pancreaticoduodenectomy, or briefly attributed as a Whipple procedure. And these patients, they are at risk for developing leaks in all of the areas that the small intestine is reanastomosed, whether that's to the bile duct, whether or not that's to the stomach, or whether that's to the lower portion of the small intestine. So with a Whipple, there's a little bit higher risk of complications because of the way that you're reconstructed after surgery. A patient that undergoes a distal pancreatectomy or splenectomy typically has a tumor that's located in either the body or the tail of the pancreas. So the end of the pancreas, as well as the spleen, are removed during surgery. One of the things that we do to help minimize risk in these patients is to also allow the patient who undergoes a splenectomy to undergo pre-surgical splenectomy vaccines. We coordinate this with the pharmacist at the hospital to make sure that they get these done and minimize risk of potential infectious diseases that may occur by not having a spleen in place. So for patients that undergo surgery for whether a distal pancreatectomy or pancreaticoduodenectomy, they do have a risk for a leak or a fistula developing. A risk for a leak is a little bit more common in a patient that has a soft gland. What we mean by that is patients that have had an adenocarcinoma arise in their tumor typically have had their bile duct blocked. They typically presented with obstructive jaundice. And so the gland is really hard and firm. It actually makes it easier for us to sew the small intestine to those components once we're moving in the specimen. Patients that have a pancreatic neuroendocrine tumor or some other like cystic process it creates a softer gland and makes it more difficult for it to be sewn together, which then in turn leads to a higher risk for a potential leak. These patients, like gastrectomy patients, may also struggle with delayed gastric emptying. And what that means is because a portion of the stomach was removed during the operation, they may have difficulty having things pass through at a normal rate and regulation. This may become a symptom such as fullness or inability to tolerate anything but small, frequent meals. As we look at patients that have undergone pancreatic surgery, it's important to recognize that they are also at risk for developing endocrine or exocrine insufficiency. We're all aware that the endocrine function is really associated with glucagon and insulin production. So some patients, if they've not recently been diagnosed with diabetes, may develop diabetes in their postoperative course and sometimes significantly delayed. Another issue that patients face with undergoing issues related to pancreatic surgery is exocrine insufficiency. And that's the inability for their body to produce enough digestive enzymes, which impacts their ability to absorb nutrients. This can lead to steatorrhea or fatty stools, difficult weight loss, and issues with malnutrition. It's very helpful to assess early and often as to whether or not they have pancreatic insufficiency, especially exocrine insufficiency, so you can start them on pancreatic enzyme replacement, such as Zimpep or pancreolipase or Creon. Those are all options that are available to the patient to be able to help minimize those risks. Overall, pancreatic surgery has historically had high mortality rates, but in high volume centers, the mortality rate is now less than 5%. Of course, patients that are elderly, have significant risk factors or morbidities may require or indicate a higher risk of mortality. Common postoperative complications associated with endocrine surgery include surgeries related to the adrenal gland, so an adrenalectomy for either a pheochromocytoma or metastatic disease, such as a lung that has metastasized to the liver and resistant to immunotherapy, a total thyroidectomy for thyroid cancer or benign disease or parathyroid disease. These surgeries tend to be less complicated. However, when it comes to adrenalectomies, it's important to note that there is an extensive amount of time focused on trying to minimize issues postoperatively associated with hormone production from PHOs. It's important to titrate alpha and beta blockade prior to surgery to minimize the event of an adverse event during general anesthesia. Thyroid and parathyroid surgery is relatively uncomplicated. However, it's important to identify and educate the patient on potential complications associated with the recurrent laryngeal nerve or having some postoperative hypocalcemia. Both can be relatively symptomatic. So, if a patient endures a recurrent laryngeal nerve injury, it's always important to make sure that you assess their ability to talk. If they can't, it's a complete airway emergency and they need to be evaluated immediately. Although just a nuance, but also can have significant side effects, postoperative hypocalcemia can be annoying. A sign may include a positive Shopsteck sign. They may have complaints of numbness or tingling in their fingers, around their lips, or in their toes. Hopefully, this can just be managed with PO medications, but sometimes it does require rehospitalization with IV calcium and vitamin D support. Now, we've done a lot of talking about all these potential postoperative complications, disease specific, but most importantly, it's to identify the patient that may struggle from these interventions. So, we want to make sure that we are highly selective. We offer surgery only to the patient that would absolutely benefit from it. We've discussed potential risk and how to manage them, as well as the tools and the resources to minimize those risks. ERAS, which is Enhanced Recovery After Surgery, is an evidence-based option that tries to optimize recovery, decrease complications, shorten hospital stays, and improve patient outcomes by allowing the patient to drink closer or eat closer to the actual surgery, integrate multimodal medications to minimize opioid use, which allows bowel function to return sooner. They try to maintain normal glycemia. They ambulate the patients early and often introduce nutrition early as well. All of these things have been proven to show that the patient outcome is better. So, today we've talked about complicated risks for surgeries. We've talked about what we can do to hopefully minimize those things. The patient's completed surgery. They're now recovering, and we're trying to see them early and often. We want to be able to help identify and manage any potential complications that may arise. As a patient transitions from the inpatient setting to the outpatient setting, it's crucial that they understand that they're there and supported. We typically try to see patients within 5 to 7 days after surgery in the office. We try to then early identify whether or not they have a potential postoperative complication. If for the slightest inkling they have a potential complication, we want to work it up. We want to rule it out. Labs, imaging, whatever may be necessary to evaluate whether they truly have a postoperative complication. And if they do, we're going to reach out to our colleagues to also see if we can use that village to help take care of these patients. We know that multidisciplinary coordination is absolutely crucial to their success through all stages of their cancer care. Some of those people may include gastroenterology, interventional radiology, infectious disease, and their medical oncologist. So, as we've talked about today, we've talked about the role of surgery. We've had talked about being highly selective in offering surgery to patients in order to maximize the benefit of that treatment modality. We've discussed high risk features as well as ways to evaluate those risks with using different tools to help us as clinicians. We discussed site and surgery specific complications as well as ways to intervene. I hope that you've learned something today. And if there's anything that you have questions about or interested in learning more about, please feel free to reach out. Thank you so much for your time and attention. And as always, I'd love to hear from you. Thanks and have a great day.